right, welcome to episode number 1 of the Safe and Sterile Endoscope series, a 6-part educational series on the Beyond Clean Network, sponsored by Advanced Sterilization Products. And we're going to be talking to device reprocessing technicians, endoscope reprocessing technicians, infection preventionists, regulatory, you name it. If you're involved in this scope conversation, this series is going to be for you. And we're kicking off today's episode in the beginning, the history of endoscopes and endoscopy, and in particular the device reprocessing part of this equation. Today, joining us to kick off this episode, number 1, is Dr. Klaus Mergener, the Chief Medical Officer at Pentax Medical. So, Dr. Klaus, welcome today.
Thank you, Hank. It's good to be with you all, and thanks to the audience for listening in.
So, for folks who may not know you, give us a little bit of background. How did you get into the endoscopy space, and in particular, how did you start this role as Chief Medical Officer there at Pentax?
Sure. And just very briefly, as soon as I open my mouth, you can tell I'm not from this country originally. My kids still make fun of my German accent. So, born and raised in Germany, and then medical school there, and then saw the light and came to the US. And I'm a proud naturalized citizen as of 30 years ago. So, I've been here for a while. I'm an interventional endoscopist and I still practice. So I look forward to talking to you, Hank, about this very, very important topic. Been practicing for about 30 years, last 25 years in the Seattle area. And for the last 3 years, after I was president of our endoscopic society here, I sort of reoriented myself and took a part-time chief medical officer job with Pentax Medical, which I'm very fond of. One of the companies, of course, that makes endoscopes. And I'm helping, hopefully, helping the company figure out strategic issues around what kind of endoscopes and also the topic we're talking about, the reprocessing issues.
Yeah, it's always fun to talk to active clinicians. And of course, I used to be one myself. I haven't been active in the sterile processing space for a number of years now, but there's just something about being in the trenches and keeping your pulse on the real life day to day. It keeps you a little sharp, I think, when it comes to all the other fun things you can do out there in the consulting space, or even in your case, and really leading out into what the vision for the future of these devices needs to look like. So, but before we get too far into the future, of course, this episode, as I alluded to, this is episode 1 in a 6-part series, and we're going to spend the majority of our conversation today talking about how did we get to where we are today. And then the remaining episodes will really dive into all the complexities around endoscope. And there's not going to be any surprises for some of the conversations, because I think we all know it's a challenging environment. There's a lot of regulatory oversight. There's constrained resources. You name it. If it's a challenge, it seems to all intersect in this part of the industry. But let's just kind of start a little bit earlier here and talk us through endoscopes in particular. How did we get this device? Like, what purpose or role does this device play in that medical procedure?
Yeah, absolutely. And it's my favorite topic, Hank. So you
Okay,
have to continuously stop me because if I have any hobbies, it's the history of our field.
great.
Um, Endoscopes are, as all of us know, the entire audience, extremely important. When we do colonoscopies, just to get us started, it's actually, if you look at everything that's done in medicine, it's one of the most life-saving interventions because, of course, we can identify polyps and we can prevent cancers that way. So where we are today is fantastic in terms of what endoscopes can do. We're at about the 100-year mark of the beginning of GI endoscopy. And if we want to take a quick look back, it started really in earnest in the 1920s with a gentleman by the name of Rudolf Schindler back in Germany. who was an internist and had just come back from World War One and realized that a lot of soldiers and in general people who in stressful situations, they had a lot of stomach problems. And of course, there was no way of looking into the stomach at that time. You had some x-ray techniques, but that was a very crude method.
I mean, there is one way of looking to the stomach,
Yeah.
but not the way probably that we wanted to.
You're in bad shape when your stomach is being looked at that way.
Yeah, exactly.
So he was walking down the hallway one day, and he saw in a little glass case an old endoscope that an ENT physician had been using to look at the larynx. And he thought to himself, wouldn't it be possible to create a device that's longer, that's going down the swallowing tube, and that allows you to look into the stomach? Now, there had been attempts made with candles, the previous century, and all kinds of stuff. And needless to say, they all failed. Schindler must have been a unique individual because he was very research oriented, very meticulous, very sharp thinker, and he thought through this very methodologically. What would it take? How do you bend light around a corner? Because your swallowing tube is a straight shot, right? But once you get to the stomach, there's a bend there, and then you get into the small intestine. There are corners to negotiate. How do you do that? And how do you get the picture, the light back up to the eyepiece back then? So long story short is in 1922, Rudolf Schindler puts together the first usable rigid endoscope. So imagine this, Hank, for your endoscopy. This was a rigid uh, steel tube, essentially. So you're the sword swallower now, right? Taking this thing all the way down into your stomach. It worked. It worked, and he wrote a great textbook. Our first textbook of GI endoscopy was written by Rudolf Schindler in 1923. I mention that in such detail because that probably saved his life. Because what happened then is two things. He recognizes just a straight steel tube for Hank Balch for his gastroscopy is not a good idea. He needs something more flexible. And he starts working with engineers on what's called the semi-flexible gastroscope, which he was able to then produce in 1932, so 10 years later. And it had lenses in a rubber part of the endoscope, so it was bendable. And the light was transmitted through essentially not prisms because they absorb too much light, but lenses. Um, so that was 1932. Now, the Nazis in Germany came on the scene around that time. It turns out Rudolf Schindler was Jewish. He gets thrown into what they called protective custody back then, was at risk of getting delivered to Dachau, one of the concentration camps. And only because he had written the textbook, he was already internationally famous. Some American physicians then rescued him essentially by writing petitions, by getting him out of jail. And he leaves Germany in 1934 for ultimately Chicago. And he spends the rest of his life and his career in the US. He's actually the founder of the society I mentioned I was president
All
of
right.
a few years ago, the American Society for Gastrointestinal Endoscopy. Well, amazing
Well,
life story.
yeah. So obviously, he had a critical impact on the trajectory of the procedure and the device and the technique. It sounds like if he's writing the textbook on it. Um, what are some other names that folks who are curious or interested in this uh, as part of the historical advent of this technology? What are some other names they should be aware of? And I can tell that you're kind of a history buff. why is it important to know these personal stories? Like, why should someone who's reprocessing today in 2024 even care about the story you just shared, or any of these other names maybe that you're laying out here?
Yeah, I'll start with the last part of your question,
Okay, yeah,
because I think it's a very important and very good point. And we can ask similar questions about any aspect of history,
right,
right? Why is history important to us? Why is the history of our country, the United States, important to know, right? Well, it informs us of some of the struggles and how they were overcome, and it tells us about who we are today, and thereby it helps us sort of figure out where we need to go from here. So in the case of endoscopy, to address your question, um, if I look back at Rudolf Schindler, I marvel at the fact that it was all there in 1923 in his first textbook. And for those who happen to be able to see the video, there it is. It's a first copy of the 1923 textbook that Rudolf Schindler wrote. And Hank, it is all there. It's not just here's how I built a new shiny endoscope, but he talks about quality. He talks about the importance of training gastroenterologists well. So not any dude should be able to pick up one of these things and put it down your throat. The training aspect was very, very important. He talks about the importance of research. How do we advance our field systematically, not haphazardly? So that is why I think we all should go back. Um, and in our case, we're going about to talk about infection issues, understand where were we several decades ago in terms of how did we clean these first devices, and what were some of the aspects that we learned over time were problematic, and what do we address going forward. So that's the history aspect of it. Just very briefly, a couple of, if people are as nutty as I am about the history of endoscopy, the next big milestone after Schindler was a gentleman who lives in Knoxville currently, Dr. Gene Overholt, who in 1961, 63 was when he published it, develops the first fully flexible lower endoscope. So I referred at the beginning of our conversation to the fact that colonoscopy is one of the most life-saving procedures. You might say that Dr. Overholt got us there by going from Schindler's semi-flexible scope. It had a rubber part and still had a steel part to it. It was semi-flexible. Overholt's first type of colonoscope was the first fully flexible lower endoscope. So Gene Overholt is someone who is a big, big name for us and a past president of our society and all of this. And then in a moment, when we talk about infection and the early control and the early days in endoscopy, I will mention anecdotes that Dr. Jerry Way told us. Dr. Way was the first one to do a full flexible colonoscopy in the late 60s. Then that's how long it took to develop a full colonoscope. And he can tell great stories, and he's still living happily in Connecticut, and a past president of our society. Jerry tells great stories about the early days of cleaning these devices.
wow, yeah, no, that's terrific, and that's even the few names you threw out, and obviously there's many others that have had large and small impacts on this technology, but it does highlight the human spirit and human ingenuity in these are challenges that were in front of them in the 1920s and the 1960s that someone said, I'm not just gonna keep letting this challenge sit there unimpacted. I'm going to take it upon myself and try to push into this, not knowing whether or not they're going to be successful or how long it's going to take or if anyone's going to believe them. Uh, and yet they push through it anyway. So I think
That's
that's an
ex
important call for
that's
us.
exactly right, Hank.
Yeah.
I'm not content with the status quo. You
Yes.
know, the way we make progress, whether it's in infection control, whether it's in endoscopy, or probably anywhere else in our lives, is to say we recognize there's a challenge and I'm going to try to do something about it. And there's plenty of failed efforts and everything else, but
Right.
that's what it takes to drive things forward.
Well, speaking of challenges, let's go to what you kind of what you already alluded to. I guess you kind of set us up here on the cleaning and sterilization challenges. Obviously, by the 1920s, the healthcare industry already knew about infection. We knew infection risk. We didn't know everything we know today. There's been a lot of knowledge between then and now, but like these basic concepts of uh, we should probably clean these devices and we should be designing them with some sort of reprocessing in mind. What were some of those early challenges and how did they confront them?
Yes. So in the very early days, I would say we knew about dirt,
Hmm.
right? We knew it probably was a good idea to clean something before you reused it.
Right.
Now the whole issue of bacterial transmission and disease transmission was just starting in these early days to sink in. So, the cleaning approach was a good sponge and soap essentially, and lots of water. And you wipe it down, and off you go again for your next exam. That was essentially the cleaning in the 20s, in the 1930s, 40s, 50s, all the way up to the 1960s. Jerry Way, who I mentioned a moment ago, did the first fully flexible colonoscopy in 1968, tells the story that the person from the Olympus company, which made the first fully flexible colonoscope that he used, a Mr. Oneda, there was only a handful of these scopes in the world, and Dr. Way was one of the innovators, so he got one of them to try. And, at some point, Mr. Oneda would come back and pick up the scope because he wants to show it to other physicians. So he comes by, he picks it up, he holds it under his nose and sniffs it to make sure it's clean. So that
The
was the
old smell test.
that was the old smell test that started for those who are listening to us in the infection control business. That's how your specialty started. It was with a sniff test of the old colonoscope. And Jerry tells the story that his nurse then looked at Mr. Oneda and wrinkled her skin and said, "Mr. Oneda, would you pass that smell test?"
Oh, classic, classic. Well, what's interesting, not to get us off topic here, but there is still a bit of the smell test in practice today, and one of the ways that we kind of educate our reprocessing technicians is uh, use all of your senses except for your sense of taste. And that's probably one you can leave out. But everything else you want to engage in this reprocessing process. So, all right. Let's skip forward a little bit to where we are today in the anatomy of the modern endoscope, right? So you've kind of set up the story for how we got here from the 1920s innovation out of rigid, semi-rigid into fully flexible. But here we are in the mid 2020s now, and we've got extremely complex devices compared to those earlier devices that we've been talking about. Uh, Talk us through how you would maybe describe the anatomy to a beginner, kind of entry level healthcare provider.
Oh, absolutely, and fantastic question, Hank. Thank you. So I mentioned the name Gene Overholt, 1961, first fully flexible lower endoscope, for a reason, because it was actually, if you look at things, it was all there at the time. The very first endoscope had an instrument channel which is part of the complexity of today's endoscopes and the difficult part to clean. It's the tiny little channels that run through endoscopes, right? So it had that instrument channel. It had a suction and a water flushing channel, which again, additional channels, difficult to clean. Um, and it had an up, down, left, right control. So in you might say in a different way, not much has changed since 1961. A lot has changed in all other technologies in the car industry and everything else. Our endoscopes, to some degree, still look like they did 50, 60 years ago. Now, that said, as you point out, they are complex devices. And the difficult and the challenging part for all of us is how do we clean a device that has tiny little channels running through them? And we'll talk in a moment about the specific infection risks. In the case of a so-called ERCP endoscope or an endoscopic ultrasound endoscope, they have a tiny little metal plate at the tip, so-called elevator, that if bacteria get underneath it, there's additional crevices that can be difficult to clean. So very complex, very difficult to clean. And initially, ever since Dr. Wei, late 60s, first colonoscopies, and the field takes off, and the 1970s and the 1980s come, we thought that just putting them into the equivalent of a dishwasher and a different way of soaking them and wiping them down with a sponge would be good enough. And more recently, we learned some of the significant outbreak issues that can occur.
Right. Yeah, you alluded to, in some sense, the technology itself, at least the basic technology, hasn't changed too much in the 1960s. Maybe the structure, we'll say it that way. Um, Importantly, what has changed is the infection risks, or in particular, the kinds of bugs that could get in and on and through these devices now that we're fighting from the reprocessing side. Not that there wasn't already dangerous bugs out there, uh, but now we have something called super bugs, and they're not super because they're good. They're super because they're really, really bad. How does that impact this conversation we're talking about today? We've got components that are getting increasingly complex, like you alluded to a few of the technologies just now. And I'm assuming it's only going to continue to get more and more complex, more and more digital from here as we're able to do more things internally, which is the whole purpose of these devices to begin with. Um, how do we confront those two intersections? The bugs are getting more dangerous, the devices are getting more and more complex, and then here we're standing in the middle as the reprocessing industry thinking like, how do I solve this challenge?
Totally correct. So, the devices have, of course, evolved a bit since the 1960s, and they have gotten more complex. But you're 100% right. What has also evolved is on the patient side, we now use antibiotics. Every time someone walks through an ER door, they get an antibiotic before they get a handshake. Um, and so that creates antibiotic resistance and these superbugs. And then, of course, medicine has evolved to the point where we're now doing transplants all the time. We do cancer therapies with chemotherapy that suppresses the immune system. So on the patient side, we have these very vulnerable patients that are exposed to potentially superbugs from the endoscopes. So those are your three components, your three elements of risk, if you will, that we have to deal with. And what we've learned over the last, I would say, 15, 20 years, and then specifically the last 10 years, which maybe we'll get a chance to talk about here in a moment, um, is that when we think we can clean these endoscopes with just sort of standard means, wipe them down and then put them in an endoscope automated reprocessing device. As long as we follow the steps, it will be okay. And we've learned more recently that even if we follow the prescribed steps, there can be the occasional superbug that sticks to the endoscope. And we've learned more about the risk that that can potentially transfer to the next patient.
Yeah, so Dr. Mergener, you have alluded to this, and this is where we're going to start wrapping up this episode one in this six-part series. But you've alluded to the past 10 years in this industry have been a whirlwind. There's been a ton of regulatory focus, perhaps the most regulatory focus in the history of this space, specific on the reprocessing side of things. But we've got device manufacturers that are continuing to innovate. We do have these super bugs now active out here. We've got the manufacturer of the cleaning devices, the washers, and the tests, and the documentation, and the electronic tracking for all kinds of outbreak purposes. Like, we've got all of this colliding in the last 10 years. From your perspective, what has been the most impactful shifts, or the most impactful maybe challenges that have been surfaced but are yet unsolved in the last decade as we wrap?
Yes. The one word answer, Hank, to this question is 2013, because that was the year when in Seattle, at one of the Seattle hospitals, there was an outbreak detected of, you might call them superbugs. You know, the technical term is high concern organisms, whatever, um, where it was documented over the following few years that patients got infected from contaminated ERCP endoscopes and got not just the bug transmitted, but got clinically sick and eventually died. And, you know, it took a while for people to recognize this. Again, the narrative before 2013 was, well, yeah, we've seen some infection transmission, but it usually had to do with breakdown in the reprocessing procedure, right? So, again, in other words, if you do everything correct, there is no risk. And 2013, we start learning that, wait a minute, everything was supposedly done as it should have, and still people died. And that's when people really became cognizant of, we need to look at this more closely scientifically, and what do we do about it? And what happened over the following few years is a couple of things. One, we recognized non-isolated incident in Seattle, but worldwide there were 300 and some patients that documented died from ERCP transmitted infections. It happened at all kinds of hospitals, not just in one area, not just in one country, not just on one continent. So, significant issue. Now, 2014, for those Americans on the line who remember, was an election year. And the Senate election at the time, going back to the history, Hank, of some circumstances, Patty Murray, the senior senator of Washington State, Seattle being, you know, in her territory, was up for re-election. So she made it her campaign issue that this incident happened at Seattle. She manufactured a Senate report on infection control. You can find it online. Google Senate report, ERCP infections, Patty Murray, you'll find it, 2014. And it was damning. And it said hospitals were to blame. They didn't supervise this. Companies were to blame because of the instruments and the reprocessing machines. Regulators were to blame because of no sufficient oversight. That's what got the momentum started towards how do we find solutions for these admittedly very serious infections. And it led us then to not just studies on how high is this infection risk. It turned out to be a whopping 5.4% of all ERCP scopes properly cleaned still had significant organisms on them. This is the early number. Um, Led to this kind of body of research. It led to companies developing new types of endoscopes, including single-use endoscopes. And hopefully we will, in your follow-up episodes, hear a lot about reprocessing companies and companies like Pentax making new types of now sterilizable endoscopes. It started that entire movement. It was started by a political push, Patty Murray spearheading it, on the regulators, the FDA, pushing the users and the manufacturers of products to really get after it, understand the issue better through scientific research, and find technical solutions to the significant issue. And we've made partial improvements, but we still need to do better.
Yeah, Doctor, I think that is the exact takeaway that I was going to bring up is, hey, we've made progress, but there's a lot more progress to be made. And as you said, I think earlier on in the interview, the status quo is not what we're shooting for. Even if we arrive at a status quo that we feel like is much safer than perhaps 10 years ago, that's not going to be good enough because these bugs continue to evolve and we've got to continue to stay ahead of those curves. And the industry just continues to change as all of healthcare continues to innovate. So, terrific introduction here to the history of this challenge, how we got to where we are today. And yeah, we're going to spend the next 5 episodes digging into the different aspects and challenges from infection prevention, the design side. You alluded to the types of innovations that are coming out, to say, hey, we can solve a big portion of this problem by taking a step in this direction. So if you're tuning in now and we've got your attention, good, mission accomplished, and stay tuned as so we have a couple of more episodes in queue for you today. Well, in the weeks to come. But today, Doc, I want to really thank you again for your time, your passion, obviously, for this industry. Not only do you serve in this role uh, as the chief medical officer at Pentax, but you're also serving in your trade organization to lead out in the vision, for moving this industry forward. So thank you so much for what you're doing and then also for sharing your insight today.
Absolutely. Thanks. Thanks, Hank. I greatly enjoyed it. And thanks to our audience for listening in.
Well, that's going to do it for episode 1 of Safe and Sterile Endoscopes, a 6-part educational series on the Beyond Clean Network, sponsored by Advanced Sterilization Products, ASP. And as I've said a couple times in this interview, we've got more to come. Make sure that you're subscribed to the Beyond Clean app or anywhere podcasts can be heard. And get your friends, get your favorite IP, your endoscopists, get them on the line for episode 2, and make sure to push them back here to episode 1 so they can start at the beginning with the rest of us. And until we see you again, like we tell you each and every week here at Beyond Clean, keep fighting dirty.